Section 3, Pediatric Dermatology, moderated by Dr. Waqas Saad, Dr. Badrea Al-Shehi.
We know basically no question from the audience itself. So everybody has to
questions that are up.
Yeah, up exactly. بحق لنا بسؤالين لا من up. Thank you. هذا البروجرام.
Good afternoon, everybody. Welcome to this important session in pediatric dermatology. It is an honor to be here today moderating this session with my colleague, Dr. Badrea. It's my pleasure to introduce our first speaker, Prof. Santipan Dahar. Prof. Santipan, he will share his sites in Langerhans cell histiocytosis, 25 years experience. So, Prof. Santipan, the floor is yours. Any questions can be sent through the app.
And thanks to the organizer for inviting me to speak in this wonderful conference. I hope I'm audible. I hope I'm visible also. Well, I'm going to present to you a relatively uncharted area in pediatric dermatology, that is Langerhans cell histiocytosis, in which I have got, developed interest over last 26 years in the Institute of Child Health where I work. It is not working. Yeah. So this is the Institute of Child Health, 75-year-old institute, the first teaching pediatric hospital in India, where I developed the pediatric dermatology department nearly 26 years ago. And since then, Langerhans cell histiocytosis work I have been carrying out with my team. Well, I don't have any conflict of interest except that I am having a little bit of choking of my voice because of flu, last few days. Now I have recovered, but you can hear my voice not very clear, perhaps. Now coming to the pathogenesis of an etiology of Langerhans cell histiocytosis, it's so very important that there are numerous etiologies, somatic mutations, infections, immune dysregulations, and majority of this pathogenesis is not very well established. They are obscure, in fact. But this is something which is known as undefined neoplastic status. It has been given to. And cells of LCH are clonal, both in skin as well as in systemic presentation. That means in different organs. So Langerhans cell histiocytosis is a clonal proliferation, and they may spontaneously resolve also in some cases. They have varied clinical presentations and variable outcomes, and diagnosis is always a challenge because it mimics various other diseases, and that is something which I am going to highlight to you today, that how Langerhans cell histiocytosis can be misdiagnosed as something else, but how it is important to diagnose these conditions. to prevent so many things, morbidity as well as mortality of the child. As you can see, there is a lot of overlap between the, the various systemic organs and the skin. The classical presentations which all of us have read for, from our, postgraduate days, that hand-cellular Christian disease, then eosinophilic granuloma, lateral Sui disease, generalized. There are some rare, presentations which I will share with you. Some of my cases, generalized purpura can present as, it can present in some rare cases as napkin dermatitis, a very resistant type, otitis media in some cases, even chronic paronychia. So this was the previous nomenclature. Current nomenclature is disseminated LCH with hematological dysfunction, which is same as lateral Sui disease. Then chronic localized form, which is known as hand-cellular Christian disease. I'm going to share with you some of my patients' photographs for your better understanding. Then there is a condition known as benign self-healing form of, histiocytosis, also known as Hashimoto's-Pritzker's disease. How Langerhans cell histiocytosis is diagnosed? Of course, high degree of clinical suspicion, that is the most important thing, but it is to be supported by a good histopathological examination. That is the most important first investigation. And on histopathology, on ordinary HNN stain, it can confuse you, like its clinical presentations. It may look like nodular scabies, histopathologist, unless it is told clearly by the clinician, he or she might think that it is a nodular scabies or juvenile xanthogranuloma or benign cephalic histiocytosis. This is the HNN stain section of LCH, and you can see there are large mononuclear cells with irregular pale staining cytoplasm, and they have got a very hyperchromatic coffee bean shaped nuclei, and they have a tendency for epidermotropism. Histology only gives an indication, but confirmation comes from immunostaining. S100 protein is no longer accepted as a standard method. Langerhans or CD207 antibody is highly specific and sensitive, but the most sensitive is the cell surface protein, marker protein, which is known as CD1A, and the most specific and the sensitive parameter is this. This is CD1A antibody which clinches the diagnosis of LCH in a case where you are confused. Now, what are the other important investigations which you should do to do a full workup of a child with extensive lesions, right? Extensive lesions, not only the skin, but systemic involvement also. Like CBC, LFT, then coagulation profile, chest X-ray, X-ray of the long bones. What is the importance of that? I shall share with you. Then USG abdomen, CT, MRI of chest and brain as and when required. Don't do it on the first go. Only when there is telltale, suggestions that the child has got underlying involvement of the organs, then only go for that. This is, our study of 126 cases of Langerhans cell histiocytosis over 26 years from the Institute of Child Health. Supposed to be one of the largest series in the world, where we found many interesting observations, which I would like to share with you in next few minutes. Of total 126 cases, the age was between 5 months to 12 years. Presentation as early as 5 months. Please take note of that. But most common age of presentation was 3 years. Age of onset of symptoms was 2.5 years. Time lag, this is again a very important parameter. The time lag is approximately between 1 to 1.5 years. That means it is delayed, the diagnosis is delayed. And when the diagnosis is delayed, the child also suffers a lot, more chances of underlying systemic involvement. The prognosis as well as the treatments both gets, complicated and becomes, a bit difficult. Cutaneous involvement was by and large in 68% with multi-system involvement in 32% of the cases. In various forms of cutaneous involvement, as you can see, scaly papules, seborrheic dermatitis like presentations, purpuric lesions. You can read out the percentage. I'm not going to read it out for you. Then napkin rash-like lesions, vesicopustular lesions, and something very peculiar which we highlighted in our article. For the first time we found that there are lichen nitidus-like lesions, which I shall share with you soon. And the organ involvement, you can read it out, that what are the various organ involvements and how do they present, in lung, failure to thrive, lymphadenopathy, skeletal involvement, hematological involvement, then liver involvement, spleen, CNS, and other organs. Now, coming to current histiocytic society criteria, risk of the organ involvement, risk depends on what system is involved and what is the degree of parameters, various parameters, investigative parameters you are actually analyzing. Look at the anemia, what is the hemoglobin percentage, and similarly in enlargement of the spleen and various other organs. You can read it out from the screen. So here you can see that some of the interesting presentations of this child. Initially, the lesions over the back, you see, we missed actually, and we learned from our mistake that this particular child was missed, and we could diagnose this child only after follow-up of 2 to 3 years. Initially, we diagnosed it as lichen nitidus, and that continued when the child had presented only with lichen nitidus-like lesions over the back, only few lesions, unless and until the child came up after approximately 1.5 to 2 years with purpuric lesions. And then lesions over the hands and feet is very characteristic, very difficult type of seborrheic dermatitis, maybe Langerhans cell histiocytosis. So these are the lichen nitidus-like lesions which some of our children showed, and we highlighted in our article, which have not been mentioned earlier in earlier series. This is hand-sullar Christian disease, as you can see, that the lesions are present over the forehead as a tumor. And if you do a CT scan, you can see the tumor. This child was very unfortunate, was checked by the ophthalmologist because of exophthalmos, and they could not make out anything, even though the child had some lesions on the skin. And that's why the importance you must highlight to your friends in other specialties, that whatever happens on the skin, please refer it to a pediatric dermatologist in case of a child, because some important clue might be there. And the child had extensive lung involvement with infiltrate, as you can see. And the child had ascites, as you have seen earlier, and unfortunately we lost the child. In the skull X-ray, you can see the osteolytic lesions. This is a very characteristic of Langerhans cell histiocytosis. Some of the rare presentations, we found that in a child, very severe recalcitrant napkin dermatitis, and it was not responding to topical steroid and other things of napkin dermatitis. Then, because of our previous experience, we did histopathology, and it came out to be Langerhans cell histiocytosis. However, it is not always so. There may be very on the other side, on right-hand side, you can see a very innocuous-looking, mild-looking napkin dermatitis, but that still came out as Langerhans cell histiocytosis. Then, chronic paronychia can be a presentation of Langerhans cell histiocytosis this child had, and initially was treated just like chronic paronychia, and topical antifungal, antibacterial antifungal combinations, and so on and so forth, unless and until we thought that it could be a case of Langerhans cell histiocytosis, because we have known and we have seen, and that's why such large series has come out. I can see I have 2 minutes 29 seconds, so I'm quite aware of that, don't worry. So there is multiple purpuric lesions over the legs, ordinarily treated as enoxol and purpura, but it is coming and going again, even with steroids it is coming back. So that should raise the suspicion. So at the end of all these things, what you get from my talk is that high degree of suspicion is key to make a diagnosis. I shall be talking about that in the conclusion part. This is one of the rare form of Langerhans cell histiocytosis. discussion I have already mentioned. I am not going into detail. High degree of suspicion I have repeatedly said. Now coming to the treatment part, by and large when it is limited to the skin and there are only few lesions, it is the job of the dermatologist. So these are the options we have got. Otherwise, when it becomes systemic therapy, systemic involvement, multi-system involvement, we always collaborate with our pediatric hemato-oncologists because they are the masters for treating such cases. We are not the masters. And there is a huge medical legal issue for treating such cases. We are not supposed to treat them. We can only help them to diagnose it. And these are the options they use for treating extensive Langerhans cell histiocytosis, some of the cases which I highlighted to you. The pediatric hemato-oncologists, they use the cytotoxics actually, all the different types of cytotoxics, including the newer one. Now, bad prognosis when all these parameters are there, as you can see. However, prognosis has changed drastically over a period of time. Earlier, it used to be considered as a, malignancy in all cases of Langerhans cell histiocytosis. The moment you write, as if you are writing, death certificate for the child. Unfortunate, but this is true. But over a period of time, the prognosis has been, undergone a sea change. And we have been seeing from evidence-based medicine to the era of precision medicine, the concept of cure is going to be strengthened in Langerhans cell histiocytosis. I think that is the very important message from this particular presentation of mine I want to share with you. Before I end, I must request all of you to join International Society of Pediatric Dermatology. Membership is free. Dr. Marco is our dynamic Secretary General. Also, please submit your contribution to Indian Journal of Pediatric Dermatology, one of the 5-6 pediatric dermatology journal in the world, which is indexed in Clarivate, and there is no processing charges. Thank you very much.
Thank you, Prof. Sandeep. I think, Prof, you will continue your talk about the next presentation, Challenging Pediatric Dermatology Cases from My Career.
Yeah, I'm moving on to my next presentation. Actually, because before I could start talking, the clock has started ticking in. So I have to move fast, I understand. So I don't have any conflict of interest. Here I'll show you plenty of photographs of my interesting patients. So this is very important conflict of interest declaration of taking the consent as well as the assent. Let's come straight away to the patients because they will be more interesting to all of you. 7-year-old boy with pigmentation for 1 year, weakness for 2 years, icterus of conjunctiva you can see. There was hypotension. As you can see, pigmentation of the fingertips, interdigital places, particularly distal interphalangeal joints, and the hyperpigmentation of the tongue. I'm sure that you can make the diagnosis. What is the diagnosis? Let us make it interactive. Some of our junior colleagues, what is the diagnosis? Hypotensive child, pigmentation of the fingers, Addison's disease. Yes, rightly thought, it is Addison's disease. Correct, but there was something more twist in the tail. So our pediatrician internist were very expert. They were not happy with it, just Addison's disease because they got a history from the mother that child is having difficulty in deglutition or swallowing of the food. So they went forward, further, and a barium swallow esophagus was done, and it looks like just like a beak of a bird, and this is known as achalasia cardia. So what it is? The child has alacrimation, as I highlighted to you at the very beginning. Look at the eyes. I said achalasia, alacrimation, and adrenal insufficiency. And this is known as AAA syndrome or Algrove syndrome. And we published it also. Many of our children in the OPD, our residents and postgraduate students, they are so over-enthusiastic because we have diagnosed many Addison's disease of late. So they will come and say, sir, this is not Addison's, I believe. Looking at the pigmentation, they will ask, sir, is it Addison's disease? Looking at the hyperpigmentation. So I am literally fed up over the last 2 decades telling them, look, in our type of skin, skin of color, oral hyperpigmentation, maybe a normal feature. You call all the siblings and the parents, you will see 60 to 70% of them will have oral hyperpigmentation, not only of the gum or lips, or even the mucosa and tongue. And we published way back in 1995 this particular feature, which is now in all standard textbooks and pediatric dermatology books also. Coming to the next case, a 3-year-old girl with fever for 6 months, hyperpigmentation over the face, I'll show you, and ulceration over the elbow for 1 month. Look at the face. This child was miserable. 3-year-old girl having fever for 6 months, with at least 10 courses of antibiotics of different types, even antifungals she has received, with different kind of diagnosis by our pediatrician colleagues, gradually developing hyperpigmentation. Nobody could make out anything. And at a very later stage, we are invited to examine the child, as it always happens, unless there is a coordinated approach which is now, developed in our setup, in our country, in pediatric dermatology. So there is swelling of the eyes, which you cannot miss simply. But something more tricky is, see, look at the elbow. It is swollen, and it is ulcerated. Something white is coming out. Can somebody tell what is that ulcerated area and what is that white material? Excellent. This is calcinosis cutis. Brilliant. And the ulceration is basically because of vasculitis. In childhood dermatomyositis, 2 very important features are widespread vasculitis, and second is widespread calcinosis. Here you see both these 2. And when we did the X-ray, it is showing, calcinosis of the muscle also, which is very obvious. This is what I have already told you. Another child, 8-year-old girl, having these type of lesions, and the misery, the child was unable to, hold the school bag and raise it. And he used to get scolded by the parents as well as by the teachers that you are feigning so that you don't have to, go to school. You are just trying to avoid going to school without understanding the child is developing gradually proximal myopathy. That is the tragedy because of dermatomyositis. And this child was having this type of linear hyperpigmented as well as erythematous rashes for 1 month. There was no itching, no burning, no history of fever in this particular child. There was no history of topical steroids, so there is no chance of thinking those linear lines are stridistency. So what investigations would you advise? We could immediately think, because we have earlier seen such cases. We advised this panel of investigations, and all of them came positive. Though ANF has got not much importance in dermatomyositis. But look at the face. It looks like as if this is dermatitis artifacta. Somebody has painted on the face. Something very interesting. And I also didn't know, started searching the literature, and I found that this has already been reported. This is known as flagellate erythema and pigmentation in dermatomyositis, which is an extremely rare presentation of childhood dermatomyositis. And that's why we, reported it. This is another very interesting story. Please listen to it. How does the story unfolds? This 17-year-old boy presented to us with, sudden transient episode of pain of the lower limbs, not to us, to multiple specialists, as diagnosed initially to the rheumatologist, diagnosed as seronegative spondyloarthropathy and treated with salazopyrin. The child had episodic pain of lower lumbar region, saw a neurologist, diagnosed as, lumbar spondylosis. Then the child was diagnosed with hypertension, saw a pediatric internist, diagnosed as, benign essential hypertension. And there are papular lesions on the trunk. Nobody bothered to ask a dermatologist to look at the papular lesions. And the diagnostic clue remained in that only. There was decreased sweating over the periphery. Then the child saw a nephrologist because of proteinuria, progressive renal impairment, and all these investigations were done. So, look at this skin. Any diagnosis? Fabry's disease, excellent. So I think we can diagnose it easily. But the problem with the other specialist was just like the old story in Indian Aesop's fables, that the one elephant and the six blind persons holding the different parts of the elephant and explaining it in a different way as they feel it. But the single reason is that the animal is elephant. Here the single reason is the disease was Anderson-Fabry's disease. And the classical eye lesions, I immediately sent the child to my ophthalmologist friend. I asked him, have you seen Fabry's disease? Do you know what is called cornea verticillata? He said, yes, I have seen one case. I said, then I'm going to send it to you. This is known as cornea verticillata. As you can see in the cornea, there are multiple branches of the leaves like presentation. They are all deposits of glycosphingolipid because galactosidase A deficiency, a very important enzyme deficiency. So this is a case of angiokeratoma corporis diffusum of the body, cornea verticillata of the eye, and the final diagnosis was Anderson-Fabry's disease or Fabry's disease. Coming to the next case, a healthy newborn of 5 days, skin lesions since birth, and baby cries out on pressing the lesions. Tell me how many of you, of course not Dr. Marco, he is not allowed to ask any question or say anything. How many of you go to neonatal intensive care unit or NICU? How many of you work in a child hospital? I can see only few hands being raised. Wonderful. At least I could see 2 hands. So if you go to NICU, I'm sure that this is something which is not uncommon. And this type of lesions, when you press, the child winces. It is so tender. You see that, I'll show you number of pictures of this baby. This is very important because the parents, they do a lot of panic. And my pediatrician colleagues in the department also, they'd start doing panic. Any test in such a baby you would like to do? Yes. Answer is yes, and you will do a serum calcium level. As serum calcium level is often raised in these babies. The moment I say so, I can see my good friend and colleague in International Society of Pediatric Dermatology is just nodding and smiling. So the diagnosis was subcutaneous fat necrosis, and in which there may be raised serum calcium, hypercalcemia, hyperglycemia, anemia, and thrombocytopenia. But majority of the cases for mild derangement of the calcium, you don't need to aggressively treat with systemic steroids or biphosphonate and all these things. That wait and observe. The moment you know, yes, I can see I have got 4 minutes 39 seconds. So not to worry. So you have to just observe these babies. And most important is the counseling. Counseling of not only the parents, counseling of your pediatrician colleagues also. That look, nothing to be done. Sometimes watchful expectancy and masterly inactivity is the key to success, rather than doing a lot of misadventure. And this is how this baby gradually started, becoming normal. I think this is my last case. 7-year-old girl presented with weakness, extreme weakness. The child was admitted in the ward with just weakness of unknown origin. And on examination, when we were invited to examine the child because the child had, hyperpigmentation over the fingers, even our residents also didn't have any difficulty in making a diagnosis. And I asked them, look at the face. The child is grossly anemic, pale, hyperpigmented fingers. So any investigation you will suggest? This is a vitamin deficiency, I'm telling you. And the clue lies there. It is a vitamin B12 deficiency, cyanocobalamin deficiency, right? And as a result, there is anemia, and there is hyperpigmentation. And if you have noticed, the hairs were also, not very much properly pigmented. They are much less pigmented, right? But even in a rural setup, or even in those places where there is no scope of, doing a vitamin D level, for our colleagues, those who are working in the rural area in developing countries, you can just give a very important clue. And what is that clue? Just do a routine examination and look at the neutrophil right? Ask a good hematologist to look at the neutrophil. The neutrophil will be hypersegmented neutrophil. And hypersegmented neutrophil is a very important parameter, hematological parameter of vitamin B12 deficiency. I think I have come to the end of my presentation, and all these photographs is from my book, Color Atlas and Synopsis of Pediatric Dermatology. This is written over last 25 years. This is the 5th edition of the book, and as I understand, this happens to be the only book in the world now in our Skin of Color, which has gone up to 5th edition. And let me share with you a good news. There is a huge international sale of this book. And, Amazon is marketing it in, Asia and other countries, America. And, in Europe, it is marketed by Wise Press. Thank you very much for your patient hearing.
Thank you very much, Prof, for the excellent presentation.
Thank
you
you.
very much. And over to Mark.
We'll move to the third lecture for today. Always pediatric cases is challenging and interesting. So welcome to Dr. Mark Koh-Jain, and he's going to present today eczema mimicker in children. So welcome, Dr. Mark.
Thank you. Thank you. Can you hear me? Thank you for the kind introduction. So it's good to see so many of you all here staying back for the pediatric dermatology session. It's always nice, especially when there's aesthetics going on, but still a good crowd here. So to make things more interesting, we're going to have a quiz. All right, so I have 10 eczema mimickers in there. I think we'll show the QR code to download. Okay, these are my disclosures. And what I'm going to talk about today, firstly, is presentation of eczema in infants and children, but more importantly, what the mimickers are both in infants as well as children. And I'll talk more about the common mimickers as well as the more sinister ones that you really don't want to miss, all right? So AD is the most common skin condition worldwide, and even in the Gulf states, you can see that the numbers are, in more than 15-20%. Early on, they like to present in a very seborrheic dermatitis phenotype. So eczema or AD doesn't occur at birth. If the mother comes and says he's had a rash from birth, this is not atopic dermatitis. So it usually starts in the first few weeks of life, and very often they present with a seborrheic dermatitis phenotype with the scaling on the scalp. Sometimes we call it cradle cap, also over the intertriginous sites. Many of these go on to develop the more classical atopic dermatitis features. When they hit about a few months old, they like to get it over the face, and a lot of times there's a lot of saliva that causes that irritant dermatitis. And the classical flexural dermatitis usually starts after about 6 months or when they go into the first 2 years of life. Very often, they can present with, the infants can present with this annular morphology, and often this is misdiagnosed and wrongly treated as for tinea. So a lot of them come in from the GPs with topical antifungals, but in actual fact, they have atopic dermatitis, but more in the annular morphology. Of course, if it gets more severe, you can see that it will affect more of the body. All right, so now, this is the start of the quiz. If you scan this QR code, there will be a prize for the top scorer and the fastest scorer, all right? Okay, so everybody downloaded and you're supposed to put in event 332510, 332510, and you'll get to the voting page. Okay, so this is the first case. This is a 3-month-old infant, has a very strong family history of atopy, and has been diagnosed with mild eczema, but presented now with this rash over the face, over the eyes that started the day before. What tests may help with the diagnosis? Is it A, complement levels, B, the skin prick test to the food panel, C, a patch test, or D, a skin prick test to dust mites? All right, so you can start voting. It will close in 10 seconds. Are you all able to vote? Yeah? Okay, you have 10 seconds. And the answers, let's see. Okay, so most said complement levels, but some said patch test and some said skin prick test. So the correct answer is skin prick test to food panel, all right? So this baby has actually developed a food allergy, all right? So now we are seeing more food allergies in atopic dermatitis. So this is not really a mimicker, but sometimes a trigger of AD in infants, all right? So the more common ones that we see are cow's milk, eggs, peanuts, wheat, and soy. This baby had an allergy to eggs, and they start at about 6 months of life. So what are the red flags to look out for food allergies in AD patients, if there's very extensive recalcitrant atopic dermatitis, if there's failure to thrive, as well as gastrointestinal symptoms, think of cow's milk allergy. It starts after a few months of life and can go on until they're about 1 year of age. Another good sign that I always pick up is this eye or eye-mouth swelling, and it's quite sudden. And we see this with eggs as well as peanut allergies. Sometimes they go all red as well, almost like an urticarial lesion. So look out for this. If the parents give this history, think about a food allergy, and we may need to do skin prick test or the specific IgE test. All right, next case. This is a 6-month-old infant that presents with this rash around the face as well as the buttock area. Also has some diarrhea and irritability. So what is the most likely differential diagnosis to consider? Is it A, seborrheic dermatitis, B, tinea or dermatophyte infection, C, zinc deficiency, and D, contact dermatitis? So we'll open the voting. 10 seconds. Okay, and we'll close and let's see the answers. I think most of you should get this right. Very good, 96% got the zinc deficiency. So this is something that you really want to pick up. So there are 3 big categories of this zinc deficiency. The most classical but the rarest is acrodermatitis enteropathica, and this is the AR condition that has a mutation in SLC39A4, and the problem is that the babies cannot absorb the zinc in their gut, and it usually presents when the baby is weaning from breast to cow's milk. So that's usually at about 6 months of life, and that's because cow's milk has a lower zinc compared to breast milk. There's another entity called the transient neonatal zinc deficiency. This is a little bit more common than acrodermatitis enteropathica. It's an autosomal dominant condition, SLC30A2, and the problem is that the mom is not able to pump the zinc into the breast milk, and it presents when the baby is feeding, is on continuous breastfeeding after 6-7 months. So like in Singapore now, they have a very long maternity leave, so the moms like to feed for a long time before weaning them. So if they're not weaned early, right, then they get this, all right? So how you check is to check for zinc levels in the breast milk. Sometimes we do see maternal zinc deficiency, so you have to check the zinc levels in the mom as well, because we do see some moms who have kids quite fast after the previous one, and they are not able to restore their zinc levels. So you do have to check the mom's zinc levels, all right? So they present with this sort of eczematous psoriasiform rash, has this superficial erosion, it's sort of like a burnt look, sharp demarcation between the affected and normal areas, like to affect the perioral areas and around the genital areas. I got to thank Dr. Sandipan for that really dramatic photo on the third one, but you can see over the genital areas as well. Also, sometimes it goes onto the extensor aspects of the limbs. So a good test to screen for it is to do the ALP levels. So that comes back quite fast. Sometimes it is reduced, but of course, the best way is to do the serum zinc levels, which will come back low. So in terms of treatment for AE, you want to zinc replace for life. For TNZD, you can give temporary zinc replacement while the baby weans to cow's milk or solids. And for maternal zinc, temporary replace for the baby and ensure adequate nutrition for the mother. All right, next case. This one everyone should get right because Sandipan gave a really good lecture. So this is an 8-month-old infant with this rash for about 3 months, also has some failure to thrive, irritability, not responding to treatments. What is your most likely diagnosis? All right, we can open the polling. Is it A, seborrheic dermatitis, B, LCH, C, pustular psoriasis, or D, contact dermatitis? So everyone who listened to Dr. Sandipan's lecture should get this right, okay? And we'll... You have already told the answer. You gave 2 lectures. I didn't say which lecture. All right. 92% got it right. Excellent. I think the 8% needs to attend your lecture again. All right, so the answer is LCH. Okay, so Dr. Sandipan gave an amazing lecture on LCH. I won't talk much on this, but generally I would say that they present almost like a seborrheic dermatitis eczema-like, but there are features that you can tell, sort of give you clues, sort of hemorrhagic petechial lesions, ulcerated areas, and when you treat, they don't get better. Seborrheic areas as well, intertriginous sites, you have to think of LCH. And of course, we talked about doing the biopsy. I want to add that if you're going to biopsy LCH or even mycosis fungoides, I usually recommend to stop all topical treatments for at least 2 to 3 weeks before biopsying, because I have seen biopsies, I'm also a dermatologist, I have seen biopsies that come back negative because they are on topical steroids. So do stop the treatment before you take the biopsy. Okay, this is the fourth case of mimicker of infantile AD. 1.5-month infant presents with this sort of rash around the eyes as well as on the annular rash on the neck. What test is the most confirmatory? He's got a little bit of fever as well. Is it A, anti-Ro and anti-La antibodies, B, ECG, C, fungal culture, or D, a full blood count? All right, and we'll open the polling. So which test is the most confirmatory? All right. And it's closing in 3, 2, 1. Let's see. Very good. 80% said anti-Ro, anti-La antibodies. All right. Of course, you have to do an ECG, but that's not confirmatory. That's to look out for a complication. All right. So you want to test for the antibodies. So this is neonatal lupus, and it's due to transplacental transfer of these antibodies. Usually, it appears after the first few weeks of life when the baby gets more sun. But we have seen congenital lupus, so it's from birth. All right, and the classical is you get these annular lesions, almost like erythema multiforme type lesions. The one around the raccoon's eyes, that's classical, but you don't see that often. All right, so you want to look out for complications. The most important is a 3rd-degree complete heart block, so always do an ECG for this. The rest are more transient. So other sinister mimickers of AD in infancy, this is much more rare. If it's very severe, think of, and if there are signs of primary immunodeficiency, think of Omenn syndrome. Congenital ichthyosis, if the rash started from birth, and we do see some Netherton's patients that get misdiagnosed as atopic dermatitis. Psoriasis, sometimes we see them in infancy as well. They tend to have a more well-demarcated pinkish rash, and it's like to occur over the napkin area. Of course, we can see diaper dermatitis. A few of them may have atopic dermatitis as well, and diaper dermatitis can be due to friction, candida, or even allergic contact dermatitis. Okay, moving on to childhood phase. So this is a classical presentation over the flexural sites. It can become more severe and affect the extensor sites as well. Of course, if it becomes more chronic, it can affect and it becomes very thick, and especially in adolescents. We sometimes see discoid eczema. Very peculiar entity that sometimes I see is this urticarial dermatitis, where some areas look more urticarial, some areas look more eczema-like. And these patients, I find that I do add on antihistamines, they do improve as well on top of the topical steroids. Rarely we may see LCH as LSC as well as prurigo nodules in the older kids. Of course, think of secondary infections like bacterial infections, herpes, eczema, coxsackium, or even molluscum. One diagnosis that sometimes can be very difficult to make is arthropod bite reactions, because the parents will say that, I don't see the insects flying around, I don't see them biting my kid. And the insects are quite clever. And they always aim for the kids with eczema. All right, so if you find that these lesions are in the exposed sites, think of flying insects. If it's at the covered sites, think of crawling insects like bed bugs. All right, and you really need to implement anti-insect measures for at least a few months before all these go away. All right. Some of the Asian phenotypes are more follicular kind of eczema. We do see quite a lot of post-inflammatory hyperpigmentation, hypopigmentation, and even a leukoderma or vitiligo-like lesions in our Asian darker skin patients. Always think of contact dermatitis if it occurs at an atypical site and if it keeps coming back again. Okay, so next, case 5, mimickers of childhood AD. This is a 12-year-old boy, rash around the eyelids for about 6 months, only mildly itchy. So what's your most likely diagnosis? Is it A, contact dermatitis, B, tinea, C, seborrheic dermatitis, or D, psoriasis? And we open the poll. This should be quite simple. See a pinkish rash with some scaling, very well demarcated. Okay, 5, 4, 3, 2, 1. All right, then let's see. Great, so 80% said psoriasis, and that is the correct answer. So psoriasis is a common mimicker, or other papillosquamous disorders as well. That's the differences between pediatric eczema and psoriasis. Psoriasis tends to be less itchy, affects more the extensors. The borders are definitely more clearly defined. It's a bit more pink than red. thicker white scales, less excoriations, and much less impetiginization. But we had a very good lecture today talking about, psoriasis and eczema, and sometimes you really cannot tell the difference between the two. All right, look at the nails as well. So psoriatic nails tend to give you the 4 features of onycholysis, pitting, as well as subungual hyperkeratosis, paronychia as well. And sometimes you can take out your dermoscopy. There's also differences between eczema and psoriasis. But again, there is this psoriasiform dermatitis entity which sort of sits in between eczema and psoriasis. This was a child that we thought had eczema, but you can see some areas are a bit more well demarcated, and it worsened when we started the pillow map. So that was a sign that maybe this patient had more psoriasis rather than eczema. Okay, think of, if it occurs very early, think of a CART14 papillosquamous disorder as well. And this patient was treated for eczema for quite a few months. But you can see over that last picture there, there is a islands of sparing, and that sort of gave us a clue, is this more psoriasiform? All right, so some other papillosquamous eruptions that can mimic AD, pityriasis lichenoides, lichen planus. If you're not sure, do take a biopsy. Okay, next, this is a 6-year-old girl with mildly itchy rash over the left chest and arm for about 3 months, treated with topical steroids, strong topical steroids for the past 1 month. What test would you order to help with the diagnosis? A, autoimmune, B, fungal culture, C, a patch test, or D, a prick test. All right, and we'll open the polling. 7, 6, 5, 4. Does this add to my time? It does. All right. Okay, very good. So 94% said fungal culture. And this is tinea incognito. So we do get these cases on and off when, because of the use of topical steroids, sometimes they also use topical antifungals, but they don't use it continuously. They use it for a week and then they stop. It also sort of changes the morphology. You don't get that nice annular rash. You can see there, you don't see the annular border anymore. So this is tinea incognito. All right, so the important thing is that stop the topical steroids or even protopic antifungals for at least 2 weeks before sending off a fungal culture or biopsy. We've seen many cases where they come to the clinic, they're on antifungals, and they do the scrape there, and the culture comes back negative. I've even had biopsies that come back negative when we do a culture on the biopsy. So always stop the topical treatments for at least 2 weeks before bringing them back to do the fungal culture or the fungal microscopy. All right, case 7, this is an 8-year-old girl, has a history of atopic dermatitis. You can see some atopic dermatitis over the back of the knees, and has developed more hypopigmented patches in the last 12 months, despite pretty good control of the AD. So what test would you order to help with the diagnosis? Is it A, skin biopsy, B, fungal culture, C, a patch test, or D, photo test? All right. Okay, you have to vote a little bit faster, otherwise I can't finish my 10 cases. Okay, we're at 7, so I think we should be able to finish. Okay, and very good. So 72% said a skin biopsy, and you're thinking here, is this maybe mycosis fungoides? So again, always have MF at the back of your minds, when you see a lot of hypopigmentation, if you treat and still not better. Okay, so it's uncommon in pediatric age group, but often it gets misdiagnosed as AD. I think last year I gave a talk on MF here, if you can remember. All right, so the hypopigmented form is the most common, but sometimes they may get the erythematous form as well, especially when they go into adolescence. It's usually more well demarcated compared to eczema. So history is more chronic. AD tends to be recurrent, so it comes and goes, whereas MF is a little bit more chronic. Not as itchy as atopic dermatitis, more well demarcated. Sometimes you can see, if you look at the skin lesions, a little bit of skin wrinkling, and definitely you see more hypopigmentation in MF, all right? So definitely you need a skin biopsy to diagnose MF, and sometimes you may need to do serial biopsies. And again, very important, stop any skin-directed treatments like topical steroids for at least 2 weeks before biopsy.
The time is over for this.
Oh, is it over? I thought it was 5 minutes. Okay, do you all still want to do the quiz? All right. Okay, maybe I'll just finish up the quiz since there's 10 cases. And it will eat into my next lecture, it's fine. Yeah, okay, so this is a 12-year-old boy, itchy rashes, has been treated for AD, also has some short sparse hair. Which bedside tests will help? Wood's lamp, trichoscopy, fungal microscopy, or ultrasound, all right? Okay, we'll close the poll. And I promise to finish the second lecture faster. All All right, very good. So 73% said trichoscopy because you're looking out for these. Trichorexis invaginata and trichorexis nodosa. This is Netherton syndrome. You can see the hand mount there. And look out for early complications. They can get sepsis, dehydration, food allergies, as well as atopy. And we have had patients treated for years for atopic dermatitis, but when they get a little bit older, they get this ILC lesions, which is very classical. All right. Other mimickers of genoderm, milder forms of congenital ichthyosis, as well as patients with EB pruriginosa that often gets misdiagnosed as prurigo nodules. All right, second last case, 8-year-old girl, slightly pruritic rash for the past 4 months, has been treated with atopic dermatitis with topicals, but poor response. What history will help with the diagnosis? This one Sandipan cannot answer, okay? A, drug, B, family history, C, contact with animals, D, dietary history. Okay, and we'll close the poll in 5, a little bit different from Sandipan's case, but. Okay, very good, 44, okay, not so good, 40, less than half said dietary history, all right? So this is another type of nutritional condition that we don't see that often in Singapore because everybody just eats too much, but sometimes these kids may have very fat diet. This patient only ate fish, right? So this is deficiency of vitamin B12. So, even though we live in a very advanced community here, always have nutritional deficiency at the back of your mind, especially if you treat and it's not better. So they like to present, again, like very superficial erosions, almost like a burnt look, and more in the sun-exposed areas. Okay, last case. 14-year-old girl, itchy rash for the last 2 years. She's very quiet, has had some school bullying. What would be your next step to help with diagnosis and management? Is it A, a skin biopsy, B, psychological assessment, C, genetic testing, or D, fungal microscopy? Okay, so this is the last case. I promise I'll finish with this case. Very good. So 89% said psychological assessment. So this is dermatitis artifacta, which often also is a mimicker for, okay, we won't show the, okay, I wasn't going to show who is Dr. SK? Okay, come look for me later. I'll give you your prize. Excellent. Okay, we don't have the names for 2 and 3. All right, so always think of psychological issues as well, in patients with eczema. So sometimes they may have eczema and then the psychological issues just worsen it, all right? So do think about it. You may need to manage with your psychologist, okay? That's what we do in KK. So in conclusion, AD is very common, but many mimickers as well. So when to suspect? If it's not AD, an atypical presentation, whether it's history or morphology, an atypical cause of disease, when there's suboptimal or poor response to treatment. So what to do? Retake the history, re-evaluate the morphology. You may need further investigations like skin biopsy, but remember, stop topical treatments first before you biopsy. And finally, as Dr. Sandipan said, ask a friend. There are always colleagues around you, all right? Okay.
Thank you, Dr. Mark.
Thank you.
So we're going to move to the last lecture for... You're going to stay with us, Dr. Mark. So your last sessions for today, which is targeted treatment in pediatric dermatology, which is being given by Dr. Mark. So, mic is yours.
Thank you. I promised to finish in 10 minutes, which I never do. Okay, so I'll talk about targeted therapies in atopic dermatitis, as well as less common pediatric dermatosis, and finally in rarer pediatric dermatological conditions such as genodermatosis. So why are treatments becoming more targeted? Because we know the pathomechanisms very well now, the immunology as well as the genetics that are involved. And for atopic dermatitis, we know that there's a lot of activation of Th2 pathways leading to increased IL-4, 5, 13, and 31. And there's this crosstalk between the epithelial barrier as well as the immune system. And of course, we've been using dupilumab now for the last 8 to 10 years. It's been approved for children more than 6 months of age, and we have done that in our hospital. More than 500 patients that we have treated. The youngest has been 6 months, and the longest duration about 8 years. I would say probably 95% would achieve at least EASI 50. 75 to 95% would achieve at least EASI 75, and 50 to 75% may achieve up to EASI 90. You get the best improvements in the first 4 months, but maximum improvement at about 1 year. So what happens after 1 year? In Singapore, a lot of our patients pay for it out of pocket, so we try to reduce the dosing frequency, but sometimes when they are undergoing stressful periods like exams, we may increase the frequency. But I think what's important now is that we know that if you can bring down that clinical disease, you can bring down that subclinical disease for a longer duration of time. They may even have disease modification such that the eczema is almost cured if you can bring down that subclinical disease. Side effects-wise, the most common we see is the dupilumab-associated ocular surface disease, which presents like conjunctivitis. And now we have tralokinumab, lebrikizumab, which are specific IL-13 inhibitors. Dupilumab blocks both IL-4 and IL-13, but there are some, initially it was thought that IL-13 was stronger than IL-4 in terms of the pathogenesis of atopic dermatitis, but now they found that you still need to block IL-4 for maximal effect. So I think for both Lebri and Tralo, the efficacy similar to dupilumab, maybe a little bit less, but the companies have said that you can dose it much less frequently than dupilumab. Side effects, they said also maybe less frequent, but we do see patients getting conjunctivitis with lebrikizumab. So nemolizumab has been approved from 12 years and above. It's coming into Singapore soon. I would say that the results show that the efficacy is less than the IL-13 and IL-4 inhibitors, but may be more effective for those with itch. However, I would feel the JAK inhibitors are better when it comes to itch. The side effects has been less frequent, especially the conjunctivitis as well as head and neck erythema. So there are some ongoing trials now. Hopefully, the indications for these drugs will come down after these trials are done. There's a new biologic on the horizon. I'm sure you heard about it, the OX40 inhibitors, and we'll hear a little bit more from them as we go along. Of course, we use quite a bit of JAK inhibitors, and for eczema, we usually use the JAK1 inhibitors, abrocitinib, upadacitinib. Baricitinib has been approved for younger age groups, so we use that for the 2 years and above, and it blocks both JAK1 and JAK2. In terms of real-world experience, I find that the JAKs work faster than the biologics, especially at the itch reduction. I find the response also more robust than biologics. And of course, it's oral dosing, so for those patients the younger kids that don't like the injections. However, we do need to do blood monitoring. And I have found a few patients that developed hypercholesterolemia even in the younger kids. However, we also still are not sure about the medium and long-term side effects, so I would say, treat them for certain duration and then try to give them a drug holiday if possible, all right? Some ongoing trials. So I think for AD targeted therapies, good results in the majority of patients, so I'm offering it faster now, so we've sort of skipped phototherapy, systemic immunosuppressants. We go, after they failed topicals, usually we talk to them about biologics as well as JAKs. However, you have to manage expectations and results are variable with small number of patients that fail treatment. So is there a better way that we can decide which treatment helps which patient? Short-term side effects are mild and transient. However, we don't have data for long-term side effects. So when you treat children, because they have a long runway, you really want to try to reduce it as early as possible, but you want that good disease control. I think there's increasing evidence that disease modification is possible, which means that we can get them out of eczema, with good treatment, and not only the eczema part, but also their comorbidities such as atopic comorbidities and even the non-atopic comorbidities. Moving on to the less common pediatric dermatosis. So we've talked a lot about psoriasis treatments. There are a lot of pharmas out there. So we know that we can block several pathways in psoriasis, and you can either block the TNF-alpha, IL-12, IL-23, or IL-17, and IL-23 on its own. So far we have used mostly the IL-17 inhibitors. In the past, we used the TNF inhibitors as well as ustekinumab. There's no IL-23 that's approved for children yet, so we hope that guselkumab will soon be approved for children. There are some phase 3 trials that are ongoing for pediatric psoriasis, so we hope for them to come up. Spisolimab, which is for pustular psoriasis, it blocks IL-36, has been approved for children in China as well as the US, those with generalized pustular psoriasis. However, it's still very expensive, and so far we have not used it yet. I'll skip apremilast. Going on to alopecia areata, there's quite a few papers now on the use of JAK inhibitors, so baricitinib, a couple of papers here. We used to give tofa, but I realized it doesn't work very well, so now we're giving baricitinib. So again, the thing about alopecia areata is that you need to treat for at least 6 months before you can see any results at all. And once you see some results, you want to go on for sometimes 1 to 2 years with the JAK inhibitor. It's been approved from 2 years of age. Itolizumab has been approved for 12 years and above, better results than baricitinib. So we have not tried this for our kids yet, but seems like they give pretty good results for the adults, so hopefully you can try this soon. There's a few studies now on the use of dupilumab for alopecia areata, and just a couple of days ago we had a talk by Dr. Emma Gutman, and she's doing a trial on the use of dupilumab for AA. So if you have patients who have AD and AA, dupilumab may be a good choice to treat both the conditions. Vitiligo, we are using topical ruxolitinib now. Do you all have it here in UAE as well? So we have just started doing it for the last 6 to 9 months. Pretty good results. These patients have failed other topical treatments, phototherapy, and we've been using topical ruxolitinib. This is a study looking at adolescents, so it's been approved from 12 years and above. Hopefully, the age will come down. Hidradenitis suppurativa, not many trials in adolescents, but we have started using some of the biologics in the past, the TNF-alpha, but now we're using more of the IL-17, so we had a few good results with secukinumab and for hidradenitis suppurativa. LCH, we talked about this. We have found mutations in the RAS pathway, and because of that, some people, or we have given, our oncologists have started giving MEK inhibitors, BRAF inhibitors for some of these patients with LCH, all right? So in terms of targeted therapies and less common dermatosis, what have we learned? We don't have large studies, so a lot of it is off-label use. The results are unknown and likely very variable, so you need to manage these parents well. Side effects-wise, you have to consider both short and long-term. Problem is we don't have a lot of documented long-term side effects. So this, again, you need to manage the expectations of patients as well as their caregivers. Finally, genodermatosis. So tuberous sclerosis, I'm sure you all see this in your clinics. We have used mTOR inhibitors because the TSC gene is in the PIK3CA pathway. Systemic indications, renal angiomyolipomas, brain tumors, epilepsy, as well as cardiac rhabdomyomas. But we have also a topical form now to treat the cutaneous manifestations such as the angiofibroma. So quite good results. We are developing a patch, sirolimus patch that can penetrate into the epidermis, and we're using that for our vascular anomalies patients. We are going to try it on tuberous sclerosis patients as well. MEK inhibitors for neurofibromatosis because it's in the MEK, the RAS pathway. So a few are out now. The one that has the best data is selumetinib, but also medemetinib has been approved. Some people have tried trametinib and bimetinib, right? So you can see here selumetinib so far has the best data, but medemetinib also has just been approved for use in adults as well as children. The effects, I would say, for NF is variable again. Sometimes it controls symptoms, but and this is for the plexiform neurofibromas, it's quite difficult to really shrink everything, but at least we can try to relieve symptoms for these patients. Congenital ichthyosis, we found a very IL-17 dominant immune profile, so we have treated some of our congenital ichthyosis patients. This was a TGM1 mutation that we treated with secukinumab, and he's been on it for the last 6 or 7 years. He is doing very, very well, and he's very happy on this. He's grown a full head of hair. Netherton syndrome, also we've been treating this patient with dupilumab. Again, his lesions have improved. He's much less itchy now, and again, he's grown back his full head of hair, and his hair now doesn't have the trichorexis invaginata anymore. But the problem with Netherton's is that we are still not too sure if they are more Th1 or Th2. This patient had a more sort of psoriasiform presentation, so we decided to start her on secukinumab, and she did improve after that, all right? They found a Th2 skew in epidermolysis bullosa, and because of that, we treated our patient with EB pruriginosa. This was a collagen 7 mutation with dupilumab, and you can see the very good improvement. Again, it is variable. This patient too didn't improve so well, but then we gave him JAK inhibitor, abrocitinib, and he cleared very well. So we are now using a lot of these JAKs and dupilumab for patients with EB pruriginosa. Of course, we can even more targeted in the future when we target all these mutations in EB as well as in congenital ichthyosis. Vascular anomalies, again, we know the pathways very well, and we have blockers for a lot of these pathways, and we've been using sirolimus for the last 10 years for vascular anomalies patients. Works very well for most of the patients. Those that don't do well, we give them the PIK3CA inhibitors. We usually do genetic testing first before we start them on this, alpelisib. And we find that alpelisib tends to reduce the overgrowth better than the mTOR inhibitors.
Dr. Mark, the time is over. Sorry for that.
All right, so that's my last slide. I'll just go to the final conclusion. Targeted therapies have become more targeted, and this is because we know the genetic basis, molecular pathways, as well as immune milieu. We try to repurpose older medications because of the pathways that we know, but we're also trying to find new medications and to develop more advanced targeted treatments. But most important is we have to listen to our parents, patients, and their families. Okay, so Dr. Sandipan talked about the ISPD, but I'll just tell you a little bit about the ASPD. All right, so we are in Asia, so membership is free. If you'd like to join, please scan the QR code, or you can go to our website. We do have the committees. If you are keen to help us, also you can write to me, and we can put you in the committees. We do have the Asian Journal of Pediatric Dermatology as well, if you'd like to publish. And the ISPD, very important as well. Again, we are growing. Membership is free, a lot of teaching, a lot of outreach, so do join us at the ISPD. So that's our textbook of Pediatric Dermatology, Asian Skin. That's actually the price, so I'll give you a copy later. And with that, I want to thank you for your kind attention.
Thank you, Dr. Mark, and thanks, Dr. Sandipan, for the lovely third session for today in pediatric dermatology. I have one question to you, Dr. Mark, regarding the Dupixent and the alopecia areata. What are the connections?
Sorry, the dupilumab and?
Alopecia areata, you mentioned some of the slides about
yes.
What's the connection between the alopecia areata and Dupixent?
So I think what they've found is that in alopecia areata, they also have a Th2 skew in their immune milieu, and that's why it seems like dupilumab may work for alopecia areata.
Very interesting. Thank you for the audience to attending the third session for today. So for any questions, you can go through the applications, and the doctors are welcome to answer it. Thank you.